Welcome to the Resilient Performance Podcast. This is Keep It Real number 25. We're going to start it off with a quote here from the book called Succeeding, written by John Reed. So the quote is, "When you first start to study a field, it seems like you have to memorize a zillion things. You don't. What you need is to identify the core principles, generally 3 to 12 of them, that govern the field. The million things you thought you had to memorize are simply various combinations of the core principles." So we just want to use that quote to kind of kick this off, and in general, just talk about what matters. You guys want to take it and run?
Yeah, I think it speaks to the need for principles, pattern recognition, and recognizing that most things are just derivations of those basic principles or patterns. Like I remember being in PT school, and it's exhausting because like in your you've got like your 3 orthopedic classes, one for the spine, one for the upper extremity, one for the lower. And like in your lower extremity course, you're learning protocols, like 10 different protocols for the knee, one for the ACL, one for the meniscus, one for total knee replacement, and on and on and on. And after a while you're just like, wow, like how am I supposed to keep track of all this? And because you're learning protocols and you're looking at all these different conditions or surgeries as unique, you forget that they're really governed by the same principles, and you actually don't necessarily need to memorize a bunch of protocols. If you look at the things that unite all those protocols, like what's one of the first things? Okay, like let's restore range of motion first passively, and then let's get some range of motion actively, and then let's build some strength on top of that, and then let's develop the ability to express that strength or express that force with more of a time constraint, and then let's make that force more elastic. And then depending on the person's needs, do we have to evade an opponent, change direction, do all these things? And depending on what the person's goal is, that's going to dictate like what your protocol is. But they're really, after a while, the more of these things you see, you realize they're not really that different. I think the more you can see things as the same, it makes things a lot easier. Now granted, each of these different surgeries or conditions might have their own constraints you have to work around. But if you start from a framework of, okay, like this stuff is actually pretty much the same. We're starting at point A, we've got to get somebody to point B, and we're just progressively overload somebody to improve their function. And then if we use those surgeries or those protocols as constraints, and we only look at like, well, what are the things that make them different? The very few things that make them different, it makes it a lot more manageable. And I think that the same thing goes for something like even, we talked about manual therapy before we were recording. If you start from the premise that like every muscle has to have its own manual therapy protocol, there's a lot of muscles in the body. And then if you think I've got to memorize those things, it's very overwhelming versus if you're like, okay, well, we're using manual therapy as a means to an end. It's a way to desensitize tissue so that people can move. There's a lot of ways to do that. And most of the time it's pretty simple. But I think a lot of times, we want to make things complicated to justify our existence. So whether it's like a rehab protocol or a manual therapy, if we look at even like a manipulation, right? I mean, if you've got to bend something this way, rotate it that way, apply force this way, and there's like 10 different techniques to get a cavitation in the same place. Are we doing it because that's what's helping the patient or the athlete, or is it more theatrical to prove that we like know stuff? And I think that, we want to justify why we spent all this time in school. So we memorize a zillion things. And oftentimes the easiest things to test in an academic program is information recall, not so much pattern recognition and looking at, at trends and principles, right? And application. Those things are harder to test. So I think there's a place for that. But at the same time, we have to take a step back and look at the bigger picture, which is why I think that quote is really so useful.
I think like one of the things that I would say almost every single student that we've had has kind of struggled with, and especially the beginning of the clinical, is when we do an eval and somebody comes in with like a relatively complex set of symptoms of various body parts and body, kind of see what we do, and then typically I'd say we have good success with that of just doing kind of simple things and trying to affect like what we can actually measure and what we actually can improve. Because when you, like you said, Doug, with these special and measures and all these things kind of memorized, you have a million pieces of information, but you have no way to connect the dots. And oftentimes, like most of the things that we're actually trying to figure out, like with those tests, we have zero control over. We can't really make much of a difference with it. So I think it's really trying to understand, like at the most base kind of fundamental level, like what are the things that us as physical therapists, with regardless of whether we're doing manual therapy or non-manual techniques, like what are the things we can actually improve and impact? Because people come in with crazy sets of neurologic symptoms and this and that, but it's like, if it's truly a neurologic symptom and there's this nerve that's irritated, we can't improve those things. Like realistically, like we're not doing something that's gonna, but if this has limited range of motion, let's focus on that first and see where that takes us. So I think, it's understanding like what's the kind of flow chart, what's the process, deciphering all the information that we can take and what's actually important. Because if everything's important, then nothing's important. So we have to know what actually matters and what we can actually impact to be able to help the clients that are in front of us. And like you said, I think kind of separating our ego from wanting to feel important, which we're all human beings. Like we want to feel like we're doing a good job. We want to feel like we're important in this whole process, but all it's like the patient or the athlete or whoever is in front of us, they're the most important thing. And all we are is guides to kind of help them get to their final goal to kind of end game.
And oftentimes, you mentioned having students come in and the basics. Sometimes as a student, like I'm sure I was the same way. And then, an early grad, you kind of want to like do something crazy. Like you want to, like that's what the best people are doing, is these like kind of out there, think outside the box type of things with like all of your patients. And it's like, there's only certain situations that some of those more advanced techniques or approaches are appropriate. And it's always like, the first question is, what kind of range of motion do they have? Like, what do the tests tell you? If we're looking at stuff on the table, we should be looking at it because we want to change it. We want to affect something that's like pretty concrete in front of us. So it doesn't really matter until you have those more basic things, looking at a special test. It's like, all right, that's great and all, but if you're still missing, 30 degrees of, like, who cares if you're nearest test? Like, let's just get you more shoulder flexion. That's where almost then it goes to like, well, diagnoses matter less and less when you just kind of boil things down to like, what are the things that truly matter? And yeah, just keeping things simple, and definitely like not trying to hit a home run every single session with people. That's some of the things you learn as a student, like, let's focus on the things we can affect, range of motion, let's get strength, conditioning, and
I think the idea of just doing the basics like savagely well is really all we, like the three of us, ever try to do with our clients. Like we're not trying to invent crazy new exercises or make things look complicated or trying to work on like a million different things at once with one exercise. Like we have a couple of goals that we're trying to achieve with each of our interventions. Then outside of that, we just try to make it as simple as we can because I think, it becomes when we have that almost like paralysis by analysis. We have so much information, we're trying to do everything all at once. It's like, that not necessarily going to help the client. So, I think it's finding your principles and finding what really matters. Like we have gotten better at over the years of practicing. And like you said, Doug, with like the pattern recognition, it's like everybody that walks in the door is different, but also kind of the same. So trying to find like, what is that and what is it that truly matters? And that's why I think the diagnosis thing was always something obviously I kind of struggled with, because I have clients now. It's like, well, what do you think it is? And like, I don't know. Like it doesn't matter. Probably doesn't matter. Like what I know is that you can't do this. So let's get you to be able to do that and see if that works. Like, what do you think is going on with it? I think you have a motion in this range of motion. So let's get that back and just kind of see what happens, versus trying to describe like a labelology that we have no idea because we're not an MRI machine. And so it's like, but in school, they try to hammer home those type of medical, like true medical diagnoses that I think when in physical therapy, in reality, we should be almost describing like movement limitations or functional diagnoses, rather than kind of trying to focus on this pathoanatomical model that in reality, with just our eyes and our hands, like we can't really determine what's truly structurally going on with somebody. But what we can prove is like this range of motion is limited. So let's focus on that. Like, you don't do this as well as you do this on this side versus that. Like, step up's harder on your left leg than it is on your right. Well, let's work on being able to do a step up. So stairs don't bother you as much on There's just a lot of things that if we understand kind of the movement level of and understand like what we're actually seeing when somebody's moving, when somebody's and like what the subjective history tells us, we can make a pretty big impact with people without having to make things overly complicated.
And I don't want to make this talk all about like diagnoses and things like that, but it's just I always think about like if you're the patient, you come to physical therapy, we're the first point of contact, and like yeah, we say like okay, like your rotator cuffs, it's angry or it's inflamed and it hurts when you go back this way, whatever. If you go to a physician, they're gonna look at it, they're gonna say the same stuff, they're gonna put a diagnosis on it, but then it's gonna be like, oh well, like go to physical therapy and like they can improve your range of motion and help with pain and strength, and then like that's how you get better until it doesn't work, and then you might need some surgery. So like the answer is usually like go to physical therapy anyway. But
Yeah.
I don't,
And I think from our standpoint, we don't need to be master diagnosticians, because you always hear like physical therapists celebrate like, oh, this person's so great at diagnosing, but your job's not just to diagnose. It's like, can you improve function? Because I can do like 10 special tests and be like, well, there's a really good chance based on the data of these tests that this person has like a labral tear in their shoulder. But unless that labral tear is so significant that it's limiting the functional outcome, like it doesn't really matter. I think that ultimately, and this is where you actually like have to treat people to get the experience and the pattern recognition, it's either so pathological that no matter what you do, you're not going to get the desired functional outcome, in which case you refer out to an orthopedist, and then they can do an MRI and they can try to find that piece of anatomy that's compromised that they actually have the scope of practice to fix. Or again, whatever pathology might exist is just a constraint to you achieving a functional outcome. And you're still going to use the same tools at your disposal you would normally use, even with that anatomical constraint. So like, I mean, me personally, like there's some things that are so obvious you just refer out right away. But if it's not so obvious, you just basically like try the stuff that you normally try that's work with 1,000 other people. And like if I have somebody that like say has like shoulder pain and they can't even do like a landmine press without excruciating pain, because usually a landmine press is pretty benign. Like there's people that they've had shoulder pain doing stuff overhead, bench pressing. You have them do a landmine press with a light weight and they feel good. Like if they do that, they're like, oh my God, my shoulder is a 9 out of 10 pain. And then you have them try like a push up with their hand elevated and a light floor press, and like everything you do hurts, and you run out of options that normally people can do even when they're pretty sensitive. It's like, you should probably get this checked out. And in the real world, that's kind of how it works. It's like, all right, like you can't do anything that we would normally do here. So maybe you should get this checked out and see if there's something anatomical that like we can't see with our eyes. But and that's kind of how it works in real life. And even I remember like with running, right? We went to the Derek Hansen seminar, and he basically used the same like 3 drills with everybody that he worked with. But where the experience and the pattern recognition comes in is like, how do you know when to use that drill with somebody? How do you integrate and incorporate that drill into the greater, the whole skill? And then what cues do you use once you've used that drill when somebody is doing the whole skill? And that's coaching. And I don't know, like that's not, he didn't like memorize a bunch of algorithms to do that. He just saw a bunch of people, and like after a while you develop this coaching language. And I think as PTs, rehab providers, like you have that movement language because you've seen enough people that you speak that language, you can see people express it. And when something is off, your kind of antenna goes up. But to do like 10 different special tests, it's like, okay, great, they have this, but like, what are you going to do? If it doesn't change what you would actually do, if you're still going to do throwers 10 with somebody after diagnosing them with a labral tear, and you were going to do that even if they had a rotator cuff strain or whatever else you thought it was, then it doesn't really matter that you identify that. Now, if the throwers 10 is so provocative that they can't even do that, then there probably is a pathology, and go refer them out.
Yeah, I think we're always kind of trying to take the process of like a reverse engineering, like from the top level, like what is it somebody wants to be able to do, and then how do we kind of peel away the layers and where they currently are now to then build them back up to that initial level. Like I think like the A running series that you're kind of referring to, Doug, is a great example. It's like I've given that A march, A skip, A run, and different running progressions to I don't even know how many athletes and clients for a million different reasons, but I give them, but it's the same, 3, 4, 5 drills that I'm giving to a number of different people just to work on various kind of qualities and that all kind of meet like what the core principles are from our treatment approach. So I think it's like when we have like, you don't need a million different exercises and a million different little variations. You need like probably your, 3 to 12 core principles or core exercises for each movement bucket or movement category. And then there's just little subtle tweaks. And like you said, how we coach and how we recognize like, why am I trying to choose this thing for this person is what allows you to be a lot more successful versus trying to almost create something out of thin air and meet the person kind of where they are without understanding where they're trying to go. I think that's where a big kind of gap comes is we're so focused on like where they currently are, how to progress them from where they are now to where they eventually need to go. And if we can't get there, like you said, then we refer them out. I think that's one of the reasons why I think that the core principle is really important, because I think all of us would be the same. It's like, if I'm doing something like you said, that should work and it doesn't work, well, then I know I probably need to refer them out. Because if I've had success with this stuff before with someone with a similar clinical presentation, well, there's probably something else going on that I can't see or that I can't necessarily feel with my hands.
Yeah. I think the same thing applies to different tools and treatment modalities that we learn, because when we learn a modality, like I remember, consuming a lot of continuing education courses earlier on, and you always feel like because you learned it that weekend, you like have to apply it on every person that you see on Monday. And then you're just pigeonholing people into these different techniques that they may or not need. So it's like, oh, you've got, your neck hurts a little bit. Well, like we're gonna find something in your neck to manipulate. Oh, you've got like your upper back feels stiff. Like, well, I just learned this cool, CT junction thing. So we're gonna do it. Like sometimes just because, again, you're providing like a novel input to somebody, like they might get some relief, but ultimately it comes down to those core principles, and the core principles are your kind of overarching therapeutic framework, your clinical decision making. And I think sometimes like we learn the tool without that overarching framework. And if you go to most courses, they often, if you ask them like, well, how do I apply this into what I'm already doing? They'll say, well, just use whatever you're already using. And there's always an assumption that like we actually learned clinical reasoning and an overarching framework. And I think a lot of times like people just pass the bucket on to somebody else. Like, well, we're just here to like teach you this, and it's your job to figure out how to use it. But if everybody takes that attitude, then we don't actually cultivate clinical decision making, clinical reasoning. And I think at a certain point, like you get that when you work with enough people. Like I know that there are certain things that like, we all got pretty deep into because we learned them early in our career. And when you start treating people and they're like paying you with their money and their time, and you kind of reach a plateau with them, you're like, well, I've got to learn other stuff, right? And like that's kind of how at least like I started studying more, running mechanics and looking at what track and field coaches were doing, because I'm like, okay, I've done what I was taught to do with runners, but they're still not getting all the way better. Like I'm missing something. And then you just got to, if you're honest with yourself and you know how to like kind of audit your own performance, you can find those things. But I think we have to find a better way than just telling people, well, you've got to treat a couple of thousand people. Like I think there is a way to develop clinical reasoning, but because education tends to be so tool driven and so memorization based, because again, that's the easiest thing to test, we often get away from like what's stuff that's really important, because once you have that filter, it's much easier to make sense of everything else. And I think that sometimes we make it harder for people to learn because we overwhelm them with so much information without giving them that filter, that it takes them years to develop that filter. Whereas if we taught kind of the filter first, then they can manage all the information a lot better.
When you have principles, it's a lot less likely that you're going to be feeling the need to like completely revamp everything you do, take a new course and learn a new tool. I think it allows us to see like the commonalities between everything and see that everything is useful in some capacity versus feeling like any one tool or any one way of thinking is like the only way that possibly works for everybody that's going to walk into your clinic.
We just had that quote post. I guess we've been last week at this point. Avoid extreme thinking and you won't be a passenger on the fad roller coaster. It's a nice way to sum it up.
I like your point too, Doug, about like the kind of auditing piece of it. I think it's like, being advice we always give to our students is just like reflecting on like the day, reflecting on the week, just you're kind of going through and reflecting on everything that you kind of seen and have learned and what your thought process is. Because I think that's one of the reasons why I feel like the three of us have become better clinicians over the years, is just from working together and kind of like auditing each other and talking shop about like what your thought processes, input from each other. Because if you're just like in the weeds by yourself every day, and it's very easy to kind of get caught like on the same train of thought every single time you go in, and you're almost on autopilot doing the exact same stuff without actually like kind of taking a step back and reflecting like, well, how could I have done it differently? What's something else I could? This is why like I love like watching you guys treat. I love watching like the coaches here at the Annex work with their athletes. So I'm like, oh, I didn't think about that. Like that's something I like. That's a good little variation. It's a good little tweak of something that I'm already doing that could be really useful for like this type of client that I'm working with.
Yeah, and I don't want to just say like, okay, it's the educational system is bad without providing like some kind of a remedy. And I think that in rehab, one thing that they could do is if you just took protocols and part of I think what makes protocols so overwhelming is like, well, I can't run with somebody till this many weeks. I can't strength train till this many weeks. And a way to make protocols look more similar is you say, look, like until people meet these functional milestones, regardless of what the surgery is, then they can't do the next thing. And I think protocols tend to be like time-based and not outcome-based. And that's what makes it hard. It's like, well, you're saying that I can't do any form of running with somebody until like 4 months after an ACL. And again, how are you defining running? If you're saying like max velocity sprinting, if that's what like your mind goes to, well, I don't even think people should be doing that at 4 months, but like you can do a running drill, you can do a low level plyometric activity. So if you see these things as like functional continuums, it's not as absolute things. And if you just treat a protocol as like protocol is a guide, but none of these things are like magic. Like we could talk about evidence-based medicine. Like for the most part, like there's no definitive resource that says like somebody shouldn't do something that resembles running for 3 months after an ACL. Tissue healing is tissue healing. We have to respect that. But beyond that, it should be all outcome driven. And the surgery, the pathology is just a constraint. And the thing is like, even if you've never treated a post-op patient, you should know what good looks like. And if they're doing something and it doesn't look the way that it should look, then they're probably not ready for it. And then if you couple that with, we have technology and ways of measuring things. If you have access to force plates, if you take your eye and you calibrate it with some data, that should tell you whether somebody's ready for the next thing versus having to memorize all these protocols. So I think protocols, like I said, they're guides. If we go off functional outcomes, we make these things outcome driven, and we just look at tissue healing and maybe whatever the anatomical site is as a constraint. And it's a lot easier than saying I've got to treat every single situation as if they're totally unique, because that's really overwhelming, and that's how we tend to learn these things.
Nailed it. All right, that's it for this episode. Tune in next week.
Thanks, everybody.
Yay.
Thank you for listening to the Resilient Performance Podcast. As a thank you for listening, please use promo code PODCAST for 10% off our professional development resources at resilientperformance.com. Also, make sure to sign up for our mailing list to receive exclusive content and promotions.